suicide, 25 attempt. So we don't, of course, have the statistics on attempts, but a much higher number of people attempt. It costs the US a lot of money. Firearms, I'm gonna move my little screen here, account for about half of all suicide. And men tend to die by suicide 3.5 more often than women. Now the statistic is that women actually attempt suicide more often than men, but men are more successful at it. White males accounted for 7 of 10 suicides in 2015. And the rate of suicide is highest in middle age and white men in particular. So that's an important population that oftentimes we overlook. I wanted to just narrow that down to Montana because the statistics in Montana are quite staggering, and especially in rural populations. So this is an area that we especially need to be aware of. And I got these statistics from, there's a suicide mortality review report that you can get online from 2016. So for all age groups in 2014, Montana had the highest rate of suicide in the United States. And this was really shocking to me and just really affected me. For nearly 40 years, Montana has been in the top 5 for suicide rates. Between 2005 and 2014, suicide was the #2 cause of death for children ages 10 to 14, adolescents ages 15 to 24, and adults ages 25 to 44. And that was behind unintentional injuries. So looking at what are some of the reasons why we might have such a high suicide rate here, access to lethal means such as firearms, alcohol use, a sense of being a burden, social isolation, and when we look at the state, we can see that, altitude, undiagnosed and untreated mental illness, lack of resiliency and coping skills, and then social stigma against depression. And this all contributes to this long-term cultural issue of suicide in Montana. Another important statistic here is that for 2014 and 2015, the highest rate of suicide in Montana is among American Indians, followed by Caucasians. So our statistics in our state look a little bit different than nationally. So when you're working in primary care, when you're working with folks, what are you looking for? What are you listening for? And then I'm going to go more specifically into how to assess more specifically for suicide. But here's what you want to be looking for. Obviously, if someone talks about wanting to die or wanting to kill themselves, you're going to do a suicide assessment. Hopelessness is another indicator of suicidal ideation. So if someone talks about feeling empty, hopeless, or having no reason to live, making a plan or looking for a way to kill themselves, like stockpiling pills or searching online, talking about a great deal of guilt or shame, feeling trapped or feeling like there aren't any solutions, having some type of unbearable pain, whether that's emotional or physical pain, and chronic pain is another area where suicide is common. So thinking about that with your chronic pain folks. Talking about being a burden to others, if there's been an increase of alcohol or drug use, feeling anxious or agitated. If someone's been withdrawing from family or friends, that might be an indicator. Changes in eating or sleeping habits, showing rage or talking about revenge, taking great risks that could lead to death. So some people are putting themselves in risky or dangerous situations. If they're talking or thinking about death more often, and then if they're showing extreme mood swings, changing from very sad to very calm or happy, so labile emotion. If someone talks about giving away important possessions, that's something you want to look for. Saying goodbye to family and friends, or starting to put their affairs in order, or starting to make a will. So any one of these or any combination of these, you want to be thinking about a suicide assessment. I wanted to talk a little bit about kiddos. So I think it can be a little bit more nuanced or less obvious, the signs for kiddos. But if they're talking about dying, if they're talking about disappearing, if they're talking about jumping, shooting themselves, or other types of self-harm, that's a sign that you want to be talking to kiddos about suicide. Changes in their personality, so a shift from maybe their usual self to being more sad, more withdrawn, more anxious or tired, even indecisive. Looking at changes in behaviors, so becoming irritable, having greater difficulty concentrating in school. Sleep patterns change, so they're waking up early, they're oversleeping, they're having nightmares. A change in eating habits, so a loss of appetite or overeating. And then if you're losing control, so acting erratically, harming themselves or others. Those are some specific signs that some of those overlap with adults, but again, kids may not have the same vocabulary. So looking more at their behavior as warning signs. So more specifically in terms of a risk assessment, the PHQ-9 is the depression screener, the patient health questionnaire 9. It has one item on there that assesses for suicide specifically, thoughts that you would be better off dead or of hurting yourself in some way. It's also good just to get a general idea of their level of depression. I'll talk about this one a little bit more in a few slides, the Columbia Suicide Severity Rating Scale. That's being used more widespread in healthcare settings and other police settings and other settings as well. And those are free, and they do a really nice job of outlining exactly what questions to ask. And then safety planning is a big part of your suicide assessment. So you're going to assess what their risk level is and then determine whether you need to put a safety plan together. So I'll talk about each of those. So for risk assessment, the most important thing that you can do is ask about suicide. And there's a lot of research showing that it doesn't increase suicide rates to ask. It's a protective factor. You want to be talking to kids. You want to be talking to adults about the possibility of suicide. And so I've just listed out some questions here, ways to ask from some measures and just some other ways to ask so that you have that vocabulary. I really like the PHQ-9. Have you had thoughts that you would be better off dead or of hurting yourself in some way? A lot of people may not use the term suicide when they are actually thinking about killing themselves. And so this gets at that very low level. You're going to kind of spread your net out wide with this one. And then you can ask those follow-up questions to get a better idea of exactly what they're thinking about. The CSSRS has a question that's fairly similar. Have you wished you were dead or wished you could go to sleep and not wake up? So that one doesn't even have anything about hurting yourself in there. Another nice question is, have you felt that you or your family would be better off if you were dead? And I hear that a lot from people, that they think people would be better off without them. So again, they may not label that as suicide. Have you had any thoughts about killing yourself as more direct? Have you ever tried to kill yourself is an important question as we go along in the risk assessment. That previous attempts are a risk factor. So then once you've asked those kind of first basic questions, approaching the subject and getting an idea about level of, or if they've had any ideation, you want to find out more about that. So frequency, intensity, duration. How long have you been having those thoughts for? How often? When they come, how long do they last? So for some people, they're really fleeting. For some people, they last all day. That makes a big difference. What is the specific content? So some people, or oftentimes people, will be vague about it because there's a lot of shame around suicide. It's really hard to talk about, thinking about yourself, wanting to be dead or wanting to kill yourself. And so people oftentimes will give a vague response. Well, yeah, I mean, sometimes I've had thoughts that maybe I'd be better off dead, or, I guess, every now and then I think people would be better off without me. Let's talk. Can you tell me a little bit more about that? What are those thoughts like? And people will surprise you. Sometimes they'll say things like, well, I thought about taking that whole container of pills. And you wouldn't have been expecting that from that response. Like, yeah, I have thought that maybe they'd be better off without me, but they've actually started to think about a method. So really digging into that and not feeling afraid to do that. Also doing that respectfully. Can I ask you more about that? That's sending that invitation for that. So you want to know more about how often they're having those thoughts, what the specific content is. You also want to know, do they have a plan? Have you thought about how you might do that? Have you thought about how you might carry that out? And again, get really specific about that. So some people will think about a method, like, well, I've thought about taking those pills, or I thought about driving my car off the road, but they haven't made a specific plan about this is when I would do it. This is exactly how I would do it. This is where I would do it. And there's differences there in having an idea about method and then having a specific plan. And that's going to determine risk factor. Do you have the means to carry out that plan? So like, yeah, if I ever did it, I would shoot myself. Well, do you own a gun? Do you have a gun in your possession? Do you know someone that has the gun? Do you have that pills? What are the pills? So finding out more information about the accessibility of that. And then intent, and that's the kicker, right? Do you intend to carry out this plan? And I really like to get pretty specific. I use like a 0 to 10 scale with them. Like 10 is like, I'm going to leave this office right now and I'm going to do it. I'm going to carry out my plan. And 0 is I would never, absolutely never, ever do that. So I like to just use that 0 to 10 to kind of nail people down. That gives me a sense. And then you can talk about that scale. What makes you a 5 versus an 8 or vice versa. So people might find that helpful. So I wanted to give you an idea of this screener, and I put the website for the Columbia down at the bottom there. And this one is for a primary care screener. I think it's a primary care triage screener. But what I really like about the Columbia is that it has the questions that you can ask in bold and underline. So the first one is, you always ask questions 1 and 2. And the first question is, have you wished you were dead or wished you could go to sleep and not wake up? And then the second question is, have you had any actual thoughts of killing yourself? And then they give you some ideas of what you're looking for there. I thought about killing myself, and then you go into more of those specific questions there. So if they answer yes to question 2, then you go on and ask those follow-up questions. Suicidal thoughts with method. So have you been thinking about how you might do this? Suicide intent. Without a specific plan. Have you had these thoughts and had some intention of acting on them? And then suicide intent with a specific plan. Have you started to work out or worked out the details of how to kill yourself? So exactly what are the details that you've worked out here? So that kind of gives you a sense of those, how to look at a plan as maybe I have an idea about a method, but this is more of my specific plan. And then that suicide behavior question, have you ever done anything, started to do anything, or prepared to do anything to end your life? And then here at the bottom, they have a response protocol to that screening. So for item 1, if it's a yes, there's a behavioral health referral, same with item 2, and then that triage level goes up by having a behavioral health consult with a psychiatric nurse, a social worker, considering a safety plan, etc. I also wanted to show you, I'm going to try to do this on my screen here. If I, you know what? I think I need to, so I think I'm going to try to do this. I'm going to stop the share and I'm going to share a different screen just because I want to show you this other measure. Okay, can you guys see that now? Yeah, okay. So this is another Columbia Suicide Severity Rating Scale. called the Safety Protocol. And I also really like this one. It's longer. So it has some of the similar questions. Have you wished you were dead or wished you could go to sleep and not wake up? Have you actually had any thoughts of killing yourself? Have you been thinking about how you might do this? Have you had these thoughts with some intention of acting on them? So you can see how these are all really similar. And then have you started to work out or worked out the details of how to kill yourself? And then it asks if they've ever done that in their life. And then what I like about this is that it also goes into these other risk factors, which I'm going to talk about in a minute as well. So current and past psychiatric disorders, what are the presenting symptoms, family history of suicide, stressors or triggers, any changes in treatment. So it gives you these other additional factors that are important in a risk assessment. It helps you identify what protective factors are there. So does this person have an ability to cope with stress? Do they have fear of death? I think somebody might be unmuted. Okay. Do they have, and then you go into, this also leads you through more of that specific questioning that I was talking about frequency, duration, total score, all of that information. So how many times a week have you had these, or how many times have you had these thoughts? When you have these thoughts, how long do they last? Or are they fleeting? Are they less than an hour? Are they 1 to 4 hours, 4 to 8? Can you control these thoughts? What are the things that get in the way of you acting on these thoughts? And then the other part that this protocol gives you is this risk stratification. So low suicide risk, moderate, and high. So low suicide risk, they have at a wish to die or suicidal ideation without any method, intent, plan, or behavior. Moderate suicide risk has suicidal ideation with a method. So they thought about how they might do it, but there's not a specific plan, intent, or there hasn't been any behavior toward that. You may still want to develop a safety plan in that moderate risk. And then the high suicide risk is suicidal ideation with intent or intent with a plan in the past month. So I like this one just because it's longer. You might not give this with everybody, but it's a nice one to use if they are indicating suicidal ideation, because it really walks you through all of those factors that we've discussed so far. Okay, so I'm going to stop sharing, go back to this one. Okay. So that's the Columbia. So in that safety protocol, it had some of these other areas that you want to be assessing for risk. So when you found out about what their ideation is, the method, the plan, the intent, you also want to be thinking and asking about these other questions. So how severe is their depression? What are their depressive symptoms? Is there hopelessness, insomnia, anhedonia, anxiety? Is there psychosis? Are they using substances? So we know that's a risk factor for impulsivity. Are they isolated socially? Certain medical conditions, so chronic medical conditions, chronic pain, those are important to assess. Have they had a prior suicide attempt? That puts them at greater risk. If there's family history of suicide or family history of a mental health disorder, that also puts them at greater risk. Family violence, having guns or other firearms in the home, and having recently been released from prison or jail. And then being exposed to other people's suicidal behavior, such as that as family members, peers, celebrities. Okay, so I want to talk a bit about safety planning, and this is a nice template. I use this in the VA, and I've used this in my personal practice. And again, I would do this with anyone that you kind of deem at moderate risk for suicide. So if they're talking about a method, if they're talking about anything beyond ideation, essentially. So if they have a method, if they have a plan, if they have any intent, you're going to want to put a safety plan together. So the first step is that you talk about what are the warning signs. So how do I know that that a crisis or these thoughts might be developing? Well, I start to feel really bad about myself, or my mood tends to get really irritable. Kind of that narrow tunnel vision might happen. Or I know that a fight with my partner always elicits this. So helping them figure out what are the triggers. Step 2 is what are their internal coping strategies. So things that they can do to take their mind off the problem. So maybe going for a walk, using my breath, visiting a friend, something like that, watching a funny movie. The next step is people in social settings that can provide distraction. So here's a friend. I'm going to write down specifically what their name and what their phone number is, so that person has that specifically all written down. And there could also be social settings. So when I start to feel down, if I go and I walk around a store, that really seems to help. It helps me get out of that isolation. They can write that store down. The next step is people that they could ask for help. So these are people, not that they're just going to go hang out with when they're feeling down, but these are people that they can call and say, I am in a crisis, or I'm feeling suicidal, I need help. So you write those down. And then any agencies that can help, so clinician's name, emergency contact numbers, and then ways to make the environment safe. So I think this is a really important part of safety planning, is to talk directly to people about who can take your gun. If somebody is at the appointment with them, can you help that? Can you take that gun and lock that up so that they don't have that? Bring in your medications. I'll keep your medications here at the clinic for you, and we'll give you your allotment each week. We don't want them to have a stockpile of pills. So really helping them eliminate the access to that to the weapons. And then another important part about suicide, when you're talking with people about suicide, is what are their reasons for living? Like what's important to them, what keeps them hanging on, what keeps them going. And typically people have at least 1 or 2 things that they can talk about and highlight, and that's important to highlight whenever you're doing the risk assessment. So typically they would do this in steps. So they'd know what their triggers are, they'd try their own internal coping strategies, they'd get together with people, they'd call people, and then they'd call the professionals or go to the emergency room, of course. So we talked about a safety plan. You can also develop a suicide contract with that person. These are the skills I'm going to use. Instead of committing suicide, I contract to my safety until the next time that I see you. Giving them emergency or crisis numbers. Having increased contact with that person, either in person or over the phone. We're going to meet twice a week instead of once a week. What other resources are available? Who else can they lean on for support? Again, having a plan for medications, weapons. Do they need to be hospitalized? Of course, a referral to psychotherapy or medication management would be appropriate at that point. So here are some resources, just some different websites that have good resources on suicide statistics and what to look for. There's the Columbia Lighthouse Project, which is the Columbia Suicide Severity Rating Scale. And then I also put a link to this article that's, I think, really interesting for us living in Montana, which is Altitude Gun Ownership, Rural Areas, and Suicide.